So in looking at the patient going through, particularly with extended rehabilitation periods, sometimes the need to provide social support from the standpoint of the clinician is really important. So again, part of this, and you'll see, as clinicians many times in a lot of in athletic training settings, a lot of times you do help to mediate the stress injury relationship with having good rapport with the patients and kind of being social support for them. That typically creates a good environment for the individual recovering from injury. As we all know, again, having discussed a lot of the psychological ramifications, particularly to pretty serious injuries, this is a really important thing. So you could certainly be a source to help mediate that stress injury relationship, again, in helping the patient just understand the injury and kind of understanding where the individual is coming from can assist as well. And there's a lot of different things. Again, your tone, your expressions, so again, it's important that you're, making sure that you're having good rapport with them, that you're kind of generating confidence, because that could dictate the patient's mood and outlook. So again, you are, as an athletic trainer, a pretty significant source of this. And you even see kind of outside, in a lot of your kind of, I guess, classic athletic settings, when you're working with sports teams, you do become kind of an outlet in general at times, not even looking at it from the standpoint of doing rehabilitation with individuals. Now, it's important to note that sometimes as individuals do progress through a rehabilitation program, they could sometimes kind of go through this sort of thing where they both are enthusiastic about getting through, but at the same time, there could still be some apprehension. Now, it's important to note that fear of re-injury is actually not the most predominant issue as far as like apprehension is concerned as someone is going through rehabilitation. So, sometimes they might have a little bit more, physically conservative behavior just because they tend to be just a little more cautious because they kind of now have a little bit more of an appreciation for the fact that, particularly once they've suffered what a pretty significant injury could bring. So it doesn't necessarily mean that they don't have good motivation or that they're, necessarily fearful. They could be, but that's usually not a predominant thing. Usually it's just they're more aware of taking care of themselves, which isn't necessarily a bad thing. Plus, there could be other things beyond kind of the psychological side, more related to the physical side of the recovery from the injury. There's, still might be some central biasing, which is, kind of that issue where even though the joint or the body part region might not be painful, but they sometimes just have difficulty kind of getting back to their skills. And again, that's something that you can actually work through physically through kind of modifying some of the rehabilitation and working on some of the neuromuscular issues related to rehab. So when we look at assessment of fear, again, this is commonly addressed when working with both adolescent or elderly patients. So this is usually something that we kind of look at when we're dealing with. However, this should be something that really should be addressed with all patients. And there's various instruments. Your textbook talks about the fear avoidance belief questionnaire and the Tampa scale for kinesiophobia. These are instruments that can be utilized and can give the clinician somewhat of an idea as, are there concerns or do they have fear of re-injury, or are there things that they just quite don't feel comfortable with yet? And that's what this is really for. And again, this doesn't have to be something that's just done with, again, the adolescent and elderly population. This can be something that you can do, again, even in your, again, more typical type of sports medicine settings where you're dealing with, younger individuals involved in competitive athletics. This could be even more so important because you could kind of learn what movements or what skills or what things maybe, still be something that are still kind of a block for them when we are looking at the as far as the fears or possible concerns with getting back to activity. So probably one of the biggest things that we definitely want to look at when it kind of comes to the psychological, behavioral side of things with rehabilitating individuals from orthopedic injuries is maximizing compliance. And this is always something that we want to see because we know that, for the most part, if you look at just about any type of, evidence-based rehabilitation program for any sort of injury, that the better the adherence is to a well, thought out, evidence-based plan, the more positive clinical outcomes you have. So, we know that this applies to both in-person sessions and at-home regimens. So it's important that if you're doing a, home exercise program, that again, you give good instructions and you make sure the patients are adhering to it. We know that with athletes, the adherence to rehab is somewhere in the range of 40 to 91%, according to your textbook. That's a pretty big range. And we know that given, how the healing process occurs and what's really needed kind of for optimal healing, that adherence in doing things is very important. So we're going to look at some different approaches to enhance this, because again, this is something that we can, definitely benefit from and assist the athletes with in the end, because our goal is to obviously have them comply as much as possible. So in looking to maximize adherence to rehabilitation, we kind of looked at the combination of medical, psychological, and various experts in these areas have kind of recommended various models to support adherence to rehab. And what we've done is have adapted them to rehabilitation from sport injury. There's essentially three theories that they've come up with. There's what's called the protection motivation theory, the personal investment theory, and what we call cognitive appraisal models. So the protection motivation theory is kind of based upon two cognitive processes. There's what we call threat appraisal and coping appraisal. So the coping appraisal involves perception of how likely the course of action will reduce or prevent the threat. So in other words, it looks at how well they're able to perform the prescribed health behaviors that are going to make them better. The threat appraisal involves their perception of vulnerability, meaning how severe the threat is to their health. So in other words, the injury or whatever they had, how serious it is. So what we've kind of learned that as far as compliance is concerned, that in regards to the protection motivation theory, the patient has to perceive the threat to be high, believe to be the treatment to be effective, and is able to carry out the treatment. So you see, if they do all of this from the protection motivation theory, they're going to likely have greater compliance. So in other words, their adherence to the program is going to be better. They'll have a lot much better outcome. Okay. So again, this is protection motivation theory. It's based on those two processes. This is kind of the setup that sort of makes it that they will be the most successful as it involves being compliant with the rehabilitation program. The second, the personal investment theory, is kind of based on the individual subjective interpretation of the meaning of rehab, and then that kind of influences their personal investment and in turn behavior. So basically their adherence is based upon kind of like their personal incentives, a sense of self-belief, and like what all their perceived options are. And what we find is with that type of situation with the impersonal investment theory, we know that if the patient is self-motivated and has social support, that again will help with their adherence. Okay, so again, they're kind of self-motivated, they have personal incentives, they have a sense of self-belief, and again, they have some social support to kind of help them with situations. Again, the personal investment theory, based on that's where adherence is going to be, most most consistent with carrying out the rehabilitation plan. And then the last one, the cognitive behavior, the cognitive appraisal model, the post-injury behavior is influenced by, again, kind of emotional responses to the injury. And that's kind of a result of interactions between personal and situational factors. So we kind of get back to looking at, is the injury a threat, which is kind of your primary appraisal, and then do they have the ability to cope or the resources to cope? That's kind of your secondary appraisal. So with the cognitive appraisal model, if again, the patient has support as a supportive environment, they're expected to adhere to the plan, they believe the treatment is effective based upon the cognitive appraisal model, they will be most likely to be successful in that situation. Okay, so there's situations with the cognitive appraisal model here that, again, you see different types of appraisals being things that will kind of help and enhance, if they're appraised in a certain way, will help enhance kind of their adherence to rehabilitation. Now, it should just be noted that sometimes these items, all these different appraisal models, they kind of get influenced differently based upon your settings. And this is kind of an important note. So again, if you're in a more, and I keep saying, a traditional sports medicine setting, meaning you're working with sports teams at a high school, college, professional, whatever, you're consistently working with a group of individuals, your established rapport there gives you an advantage as opposed to working in a clinic. Now, you can still have rapport with patients in a clinic or a non-trad setting, but because you're not seeing them as much, typically, it's going to be a little different. So it's still important to establish rapport. Certainly, if you're in one of those settings, you don't want to give up on that. But it's important to note that it's going to be a little easier in the traditional settings just because you're seeing those individuals on a regular basis. So when we look at goal setting is another thing, and that can be a positive influence. And this should be something you should be doing anyway, even outside of worrying about the psychological adherence. This is something that should just be a part of what you're doing. And you want them to be challenging, but you want them to be attainable. So that's kind of an important caveat with this, is you want them, particularly for your very active individuals, okay? So, and again, whether that's an actual competitive athlete or it's just somebody who just likes to be a male or female that just likes to be physically active, they like to exercise, the chances are they're being, possibly held back from doing something. So make things challenging yet attainable. Now, again, we got to kind of delineate between short-term goals. Again, short-term goals within the context of the ultimate goal. So these are goals that should be accomplished in no more than 3 weeks. Okay, so a short-term goal is something that you're going to get accomplished within a 1 to 3 week time frame. Obviously, the long-term goals, we know what they are. They're essentially to get the person back to whatever it is they were doing. That's obviously going to be anything beyond 3 weeks, but you want your short-term goals to kind of be accomplished within a 3-week time span. And again, remember that we want to make sure that we establish these with the patient, so make the patient a part of this. Okay, so again, remember, treatment and rehab aren't something, this is something that comes from your book, and I think it's a pretty important statement. Treatment and rehab are not done to a person, but are done by a person. Okay, so yes, there's going to be things you're doing to them, but in the end, the patient has to accept responsibility for this. So again, keeping them involved with the process. Now again, in the end, you're the professional, you're the one that kind of has to oversee it. And there may be times where they, maybe actually want to push themselves too much, and you may have to, rein them in a little bit. But at the same time, make sure you keep them involved with the process. If they're telling you that, hey, I'm feeling good with this, can we, maybe try to work with them a little bit, even if it's not within kind of a cookbook, sort of rehab plan if they're advancing and it's not going to, you're not going to put them in any danger. Make sure that you're progressing them accordingly. Home exercise adherence is important, and sometimes, particularly when you're in a clinic or a physician office setting, this is where some of this, because again, these patients you won't be seeing as often. However, even in again, sports settings, it's important to give them things to do on their own, because again, there's always benefit to that, being able to kind of enhance treatment. So we look at how can we improve home exercise adherence. There's a couple different things that you can do with this. I'm actually going to have this as a discussion board post. So I want you to, in your discussion board post, I want you to list the items that your book talks about as far as how we can improve home exercise. That's something that, again, really important. There are specific things that you can do that can kind of enhance this process. So strategies for successful rehabilitation. So again, these are just some things we could do. Again, focus on short-term goals. Again, the long-term goal, again, they're going to be kind of really pushing for that. Again, particularly if you have a very motivated, someone who really wants to get back into things. But focus on the short-term goals, because again, it's going to show the patient that they're accomplishing things along the way. Minimize suffering. So again, try to get their pain down. Decrease pain is obviously one of the earliest short-term goals we have. And the faster you can do that, again, the more confident the individual is going to be. Typically you want to look to try to decrease pain in maybe 1 or 2 treatments. Again, knowing based upon what we talked about with pain, patients perceive pain differently. That's important to note as well. So again, differentiate between pain related to healing and pain of strenuous effort. So, there's times where certain, even things that you do therapeutically may cause pain. Again, kind of educate the patient between those two different things. So this way here, they know if maybe they're pushing themselves too much, or possibly in the case of, they're worried about something hurting. Like for instance, sometimes when you're trying to get range of motion back in a joint, sometimes it's not uncommon for there to be pain associated with that. So again, kind of have them differentiate between the pain. Again, all the things we already talked about, look for the need for greater instruction if they need supervision, and then encouragement in less active patients. So we have the strategy success. You have to look to the barriers to successful rehabilitation. So one is secondary gain, and that's when you have individuals, when they look at being injured, if there's rewards for being injured, or having an injury may outweigh the rewards of getting healthy again. So you commonly hear of when if looking at it from the standpoint of athletics, and this is certainly not something that's just in athletics, but you get a starter who gets injured, and maybe their backup or whoever it was is playing really well, maybe better than the starter was prior to them getting hurt. Well, if now they're hurt, now they have an excuse to why they don't have to compete or have to worry about getting, quote unquote benched for the backup. Or you may have somebody who is out of work and they like being off of work and they're getting workers' comp, and being hurt is a secondary gain there. So that's something that could really be an issue. Substance use and abuse. Again, this affects recovery significantly, again, depending upon obviously the substance that they're using, but really, again, any type of inappropriate drug use or substance use can certainly affect the recovery process. And again, you need to make sure that you have a plan for referral in the case that you do start to notice issues with this with your patients. Social and environmental barriers. So again, time demands, lack of access. So, people living, say, in rural areas sometimes don't have the access to places to get treated at, other responsibilities they may have if they have jobs, if, something in their family demands it. And again, separation from the team can happen as well. And then depression, anxiety, sleep disturbances. Again, these things aren't as common after an injury as you would think. I mean, the sleep disturbances could just be caused by things like pain and stuff like that, but what you'd want to look into anyway if they're having sleep, if anytime you're having night pain, obviously that's a significant concern. You might need further evaluation of the injury. But again, these individuals can benefit things like relaxation techniques and even just informal counseling a lot of times could sometimes help. Obviously, if someone is really starting to, show signs and symptoms of clinical depression and things like that, again, that's something well beyond the scope of what an athletic trainer can provide. They would need to be referred at that point. So we start to look at the impact of persistent and chronic pain. So again, acute versus persistent and chronic pain, there's obviously we know the different variables as far as, again, onset and pain, but psychologically they impact people very differently. Now, again, we talked about with acute situations, you tend to not have as much of the clinical manifestations of things like depression. However, with persistent and chronic pain, you do. There is a possible link to depression. Again, when you look at clinical depression, feelings of depression or loss of interest in the previous month, again, patients are 4 times more likely to be depressed. Again, what happens, and we think of the reason why this occurs, particularly with chronic persistent pain issues, is there's an overlap in chemical imbalances associated with depression and the sensitization to painful stimuli. So, in other words, the serotonin and norepinephrine in the dorsal horn of the spinal cord get depleted in depression, and that's something that has a carryover when you look at chronic pain. So we kind of think of those two things together are a lot of times why these two things can be linked very closely together. Again, referral for care is part of our scope of practice with this. We're not going to be able to treat somebody with clinical depression. Again, can we do informal counseling, if you will, with individuals who, are maybe having a bad day or something? Or, yes, certainly. But there reaches a point. So on page 34, there's the signs and symptoms of depressive disorder that you want to look at, and a lot of common features associated with younger individuals. The key being is that the symptoms are present almost daily for most of each day and last for at least 2 weeks. So that's an important thing to note. So take a look at those and just be aware of those, and note that if they're, kind of fall within those time frames, that could be something that could be related to again, something that would need further referral. There's also a possible link to somatization. So when we look at somatization or somatoform disorder is basically when an individual has one or more physical complaints without an identifiable cause that lasts greater than 6 months. So this is basically someone that has, multiple physical complaints. We don't really know why it's happening. They've been through tests. I mean, you have to always make sure that you rule things out. You never assume. This isn't something that you assume somebody just has. And again, it's important as far as treatment for this individual. Again, provide care, establish rapport with them. Don't dismiss their experience, because again, this is a genuine problem. So we certainly want this to get addressed, whether it's pain complaints or whatever it may be. It's important to kind of treat this appropriately. So recognizing and responding to somatization, some indicators as it relates to the individual's interaction with you: increased demand of your time. So if you're working again and the patient's really trying to garner your attention and really try to get this, if they request treatment, if they start to request treatments that require special attention, if they get kind of angry when they're told they no longer need treatment, if their history is kind of inconsistent with their physical exam, those are all things that kind of start to tell you or start to clue you in that they may start to be having somatization. One of the things that can be beneficial with this, again, are kind of your various stress reduction techniques. So biofeedback can be used for this, muscle relaxation, thought stopping, deep breathing, imagery, all those different stress reduction techniques can all kind of, assist with this process of kind of treating the individual with somatization. So something that we have to definitely talk about is something called the placebo effect. So this is the belief that a medication or treatment will help. We always hear about, placebo being used in research studies. And again, this occurs with both inactive intervention and bona fide treatments. So even treatments that we know, are treatments that are used to assist with certain problems, this placebo effect still does occur. And it can have a positive influence on recovery. So we certainly don't want to neglect or think that placebo effect is necessarily a bad thing, because it's not. I mean, obviously, when we're talking about medications and stuff like that, we don't want them to be necessarily a placebo. But sometimes when we're, again, kind of treating musculoskeletal issues, that a placebo effect, even for a treatment that does work, it could also carry with it a placebo effect. So again, if the patient kind of believes it'll work, there is a chance that it's going to have a higher probability of actually helping them. So it's not necessarily it does kind of sometimes take on negative connotations, but certainly in every instance, it isn't a negative thing. So just in summary, again, it's important for individuals in all medical settings to kind of have some background in just psychological aspects of treating, whether it's musculoskeletal injuries, disease, what have you. So kind of understand injury from a psychosocial perspective. Again, identify influences regarding coping skills. Coping skills are going to be really important. We kind of mentioned appraisals and how, having coping skills, social support is very important. Again, develop strategies to improve patient adherence, identify barriers, and again, evaluate your treatment outcomes. So again, that could be just something that, just as being an effective clinician, can help with even future patients. And these are your learning outcomes.